Thank you all for coming today. This is an auspicious day. The first, hopefully, annual pediatric pulmonary update that we'll be doing, but this is a very special day from the standpoint of what it represents in the world of pediatrics. We're going to talk a lot today about the meaning and the implications of the work that Dr. Bill Northway and colleagues published 50 years ago in 1967. Before we get into the crux and the substance of the meeting and of BPD and lung development, it's my great pleasure to introduce the Dean of Stanford Medical School, who is doing us the great honor of being here. And I think this is in recognition of the profound contribution of Dr. Northway, Dr. Lloyd Minor.
Well, David, thank you very much. It's indeed my honor to be here today to join with you in the celebration of, could we adjust the microphone, please? There's a little bit of ring and feedback. Thank you. To join with you in celebrating the remarkable accomplishments of Bill Northway and really the birth of an entirely new field thanks to his leadership and his creativity. So it's a privilege for me to welcome all of you to this event in honor of Bill and his landmark paper. I'd also like to recognize a very special guest, John Clemmens, whose earlier discovery of the role of surfactant in preterm lung development first transformed the field. Because of the contributions of these remarkable physician scientists that they made throughout their careers, thousands of preterm infants can now make it home from the hospital, and their risk of later developing pulmonary conditions has decreased significantly. These pioneering discoveries are outstanding examples of what's possible when we provide precise health care for our youngest patients, care that prevents the development of debilitating and sometimes fatal conditions such as bronchopulmonary dysplasia. This approach is integral to the practice of pediatric medicine, which has long understood that infants, children, and adolescents are not just small-sized adults. Bill had this in mind when he discovered that preterm infants require specialized care undergoing ventilator treatment, not just the same care that's provided to adult patients. Because of his discovery, physicians now know that high concentrations of oxygen slow lung development in preterm infants. As a result, bronchopulmonary dysplasia has declined, and today it's a very rare occurrence. We have much to glean from Bill's remarkable breakthrough. Just as he advanced neonatology by demonstrating the importance of providing precise and tailored care to each individual patient, we must continue to provide care that's not one size fits all. And while Bill's work was certainly ahead of its time, we can now do even more for patients that have been made possible because of biomedical and technological discoveries that are occurring here and at so many other places every day. At Stanford Medicine, we view medicine today as too reactive, with physicians and patients often engaged in a frantic game of catch-up, trying to treat diseases after the fact. But, and as Bill's discovery so well demonstrated, with the revolutions today in genomics, data, and technology, we see the possibility of not just winning the race against the clock, but of actually preventing diseases before they ever occur, or when we can't prevent them, diagnosing them much earlier so that we can treat them much more effectively. We call this vision precision health, and for sure, precision health begins with the specialties of pediatrics and obstetrics. So today we're celebrating Bill's momentous achievement, but we're also looking forward. As I reflect here today on the people in this room and around this remarkable campus and university and academic medical center, I believe even more deeply that we're gathering at the right time with the right tools and the right people to change the course of children's health. Thank you for all the work you do every day to help us along this journey. Through your dedication and compassion, millions of infants, children, and teens around the world can live and live better than any of us could ever have imagined. Thank you very much. I wish you a very wonderful conference today. Thank you.
Thank you, Dr. Miner, so very much. I'd like to also introduce Mr. Chris Dawes, without whose support and generosity over the many years, the programs here would not have thrived anywhere near the degree. This meeting, in fact, was supported in profound ways by Packard Children's Health and by Lucille Packard Children's Hospital. It has been a true collaboration that our department and our university has had with Packard Children's Hospital and Stanford Children's Health. And to speak to that, we can see the beautiful new hospital that's about to be opened on Saturday. And I'd like to thank Mr. Dawes, and he'd like to share a few words surrounding his long relationship with Dr. Northway.
Well, good morning. It's really a pleasure and really an honor to be here among so many distinguished guests. And I really appreciate, David, you inviting me to participate in this event. I've had the honor of knowing Bill for over 25 years. When I first knew Bill, he was head of radiology for the Children's Hospital at Stanford. That was the original Children's Hospital. And then more recently, as we moved into the new hospital, his colleague Bruce Parker and he co-led the department. But most importantly, what I didn't know at the time was that Bill had made this incredible discovery along with many other colleagues. And working with neonatologist Phil Sunshine, who I know is going to speak in a few minutes, he discovered a new way to treat premature babies with lung disease. Bill's discoveries, as many of you know, really had an incredible impact, not only on locally, but on worldwide impact in terms of lung disease in premature babies. And it was real testimony because apparently, based on some little bit of research I did, the original baby that Phil brought to Bill actually survived because of the techniques that Bill and Phil and others developed. And I do want to say thank you to Bill. I'm sorry he's not here today, but I really want to thank him for not only leading our radiology service and doing an incredible job in that arena, but also his incredible impact on the lives of children worldwide. So again, thank you, Bill, and thank you all for being here to honor this incredible achievement. Thank you.
Thank you so much, Chris. And I'd like to introduce Dr. Mary Leonard, who is the chair of the Department of Pediatrics, who has been remarkably supportive of every aspect of this conference and, of course, every aspect of academic medicine at Stanford in general. Dr. Leonard.
Well, I'll just start by echoing Dean Miner and Chris's comments about what an honor and a privilege it is to be part of this conference. So I was doing the math and I realized I first met Dr. Northway 30 years ago when I was a medical student here and had the pleasure of doing my radiology rotation with him. I also, at that time, rotated through the NICU, and I remember the randomized controlled double-blind trials of surfactant because I remember the screens that they put up around the isolette so we wouldn't know which intervention the kids were getting. So that was my first exposure to those kinds kinds of clinical trials. And so it was really, really fun to think back on those different stages of my career. So I had the pleasure as part of this conference of going back and reading the original publication, and then I did a PubMed search, and if you look for papers on bronchopulmonary dysplasia, as of Monday, there were 6,629 of them. I think that, and I wanted to make one of those graphs where you show how many publications in each year, but it was too hard. Too many papers in too many years. So I want to also take an opportunity to congratulate and to thank the program committee. This is an extraordinary event when I think about how David and his team put it together so quickly. I think we're going to use you, David, as our event coordinator for the department looking forward. But I want to thank Christine Alvira, Richard Barth, Bill Bennett, David, of course, and Chrissa for really putting together this wonderful, wonderful event. And I look forward to your pulmonary conferences, your annual event looking forward. And it's really a pleasure to see some old friends here in the room. So with that, we'll move forward, and I'll welcome you to the event. Thank you.
Thank you all so much. So I get the pleasure of actually making some introductory comments, and of course, as would be the case, we're already a little bit behind schedule. I'm going to, through the course of today, what I'd like to do is really highlight the idea that we are at an intersection, always, between then and what comes next. The now is somewhat ineffable, somewhat unknowable. And as we move forward, we need to consider how we get to next as we progress through time. And I'm going to try to posit that we will have three fundamental themes that are going to course through each person's talk. One is that the hypothesis that progress occurs at the margins of disciplines that were previously considered distinct. And if we think about Dr. Northway's great work, this notion rings quite true. I also want to highlight the idea that context and narrative enable durable and reproducible knowledge by seeing what happens in space, in time, and knowing that there is a context and there is a theme that is elaborated over the next many hours, days, just as a patient's condition evolves over time, or as a disease evolves over time, or even the definition of a disease evolves over time, that this narrative theme needs to be woven throughout our discussions. And finally, I would like to highlight, or at least test the idea that discoveries drive care and that care drives discovery. This idea that there is a bidirectional flow of discovery that moves from the bench to bedside and from the bedside back to the bench. Never have such powerful tools been more available for the discovery process that might really enable discovery that has real impact and meaning for children, for adults, for every patient. Narrative always requires a story and a theme. And one of the themes that was quite profound relative to bronchopulmonary dysplasia was what was happening in the 1960s. In August of 1963, Patrick Kennedy, the infant son of Robert and Jacqueline Kennedy, of John and Jacqueline Kennedy, died after 39 hours of life. He was born, he was the C-section delivery, he was about 2,130 grams in 35 weeks. He was a perfectly healthy baby, but for the idea that he didn't have enough surfactant. The time was complicated because it was the 20th anniversary of John F. Kennedy's PT-109 rescue, so he wasn't around. He was at Washington, D.C., and Jacqueline was traveling on Cape Cod with her obstetrician at the time because they were fearful that she would go into preterm labor because she had gone into preterm labor previously. This was the only child that had been born to a sitting president in the past 120 years. There was profound focus on what was happening with that child and to the president and to the whole country at that moment. The baby struggled to live for 39 hours. There's no question, and for the people who are old enough in this room to really recognize what happened at that moment, that it absolutely catalyzed the biomedical research industry and the idea that we needed to move towards cures and we needed to understand the fundamental biology that underlied diseases. One of the strategies that was given to this young infant was 100% oxygen at hyperbaric oxygen tensions greater than 1 atmosphere of oxygen. We know that that probably in many ways was significantly less than helpful. But at that point, very, very few centers, as I think Dr. Sunshine will share with us, were actually giving mechanical ventilation to infants. And at that moment, unfortunately, Boston Children's was not one of those centers. The diagnosis, that this is according to the New York Times, the attending physician certified to a diagnosis of prematurity and HMD, a lung disorder that takes the lives of about half of the 50,000 infants who contract it each year. And that was in the story in the New York Times on August 9th, 1963. So as we consider bronchopulmonary dysplasia, what was then, what is next, I'd like us to remember these children and remember these patients who have influenced us all so powerfully and continue to influence us, many of whom have motivated our entire career paths. And I think the quote from Sir William Osler, one of the fathers of modern medicine, really says it quite well. Whoever studies medicine without books sails an uncharted sea, but whoever studies medicine without patients never is like never having gone to sea at all. So remember, as we move forward, giving, helping, teaching, these are the things that we do as academic physicians. We bring comfort to the ill. We work every single day to replace fear with hope, and it's our goal, just as it has been with the giants who have walked before us, Dr. Clemmens, Dr. Northway, many of the people in this room who you'll hear today, that we work exceedingly hard to ensure that tomorrow can be better than today. In the background of this paper that was written in 1967, there was much going on, much narrative work that preceded it. Perhaps some of the most powerful and important work was done by Dr. John Clemmens, who we have the great honor of having in the audience today. Dr. Clemmens, as a young scientist, was assigned a task when he was working for the military, and he can speak far more eloquently and knowledgeably to his past than I can. But if you'll permit me, he was struck by the idea that the bioenergetics of breathing just did not make any sense, that the caloric expenditure was too great, and that something must be mitigating the great work of breathing that people would experience. And there were two schools of thought on how gas was transferred, how much gas was transferred, and how much work needed to be done to transfer that gas. And it was that great discrepancy that bothered him tremendously. In 1959, after Dr. Clemmens made the first discovery of surfactant in 1956, Mary Ellen Avery, who I think many of us in the room owe a great debt of gratitude to, made the astounding innovation or leap that surfactant RDS was due to surfactant deficiency. And then as surfactant biology moved forward, Dr. King and Dr. Clemmens identified the surfactant proteins. And for people who are invested in the idea of drug discovery, they can recognize that this discovery happened in the 50s, and it wasn't until 1990 that surfactant could be delivered off any kind of investigative protocol when it was approved by the FDA. Dr. Clemmens was asked about this not too terribly long ago when he was interviewed by NPR and for a feature that was done at UCSF, and he said that it's a big, big thrill when you think you've made a discovery, found an idea that no one else has had. That's as good as it gets. And in a review, in the annual review of physiology, he said, every time scientists are forced to look outside their discipline, such cross-fertilization of minds can happen. The consequences are often unexpected and sometimes wonderful. I think that's a notion that we all can embrace. 1967, the inauguration of Governor Ronald Reagan in the state of California. One of the first recognitions of how signals are transduced from the environment resulted in the recognition of the Nobel Prize by 3 investigators who were able to identify how light was transduced to neurologic signals in the eye. It was a time of profound social change. There was much protest, much upheaval. Demonstrations were happening. Stanford inaugurated the very first coeducational living arrangement for undergraduates. And the medical infrastructure and the medical industrial complex in many ways was catapulted to the very forefront of media and the common conversations around the dinner table when Christian Barnard transplanted a human heart in 1967. A singular Stanford component to that was that just hours later, it was Dr. Shumway, who had actually hosted Dr. Barnard for many months here at Stanford, was preparing to do a heart transplant as well, and Dr. Barnard was able to get it done a little bit earlier than the people in the States, many of whom had done a lot of the immunobiology to allow that to happen. So in 1967, in February, Dr. Bill Northway was able to publish this marvelous paper. There are people here that participated in that. Dr. Northway, Dr. Rosen, Dr. Porter. And they basically concluded that BPD, in this remarkable paper, that BPD is the result of pulmonary healing in infants with severe RDS who ordinarily do not survive, from toxic effects of oxygen superimposed upon healing in infants with severe RDS, or perhaps from effects of pulmonary oxygen toxicity, healing severe RDS, intermittent positive pressure ventilation, and poor bronchial drainage secondary to endotracheal intubation. Have we answered these questions? Are these not some of the same issues that we're wrestling with today? This was a paper that was remarkable in so many ways. It has had 1,341 citations. It was cited 94 times in 2017, a paper that is 50 years old. It was cited already once in 2018. It is remarkable what deep phenotyping. Dr. Miner talked about precision medicine, and we know that precision medicine is absolutely contingent on deep phenotyping and arguably exceedingly thin genotyping. And this is what Dr. Northway was able to accomplish even in 1967. And look at the authorship of this paper. There are a pediatrician is not on there. There are radiologists and there are pathologists. Why were there no pediatricians? Phil will address that a little bit later, but it was one of the most singularly unselfish things that has ever been done, because the pediatricians did not, there was a request that they not be on the paper because they didn't want to cause any controversy about outcomes. So willingly, people like Dr. Phil Sunshine took their name off the paper so that publication could be expedited and facilitated. So through the course of the day today, we're going to build on the foundation, thinking about BPD from the very beginning. We're going to hear from Dr. Northway in a video in a moment. Dr. Sunshine, Dr. Bev Newman is going to speak to the idea of what really evolved the two diseases that we see now in a way. We're going to really hear about the foundational pieces of BPD. Dr. Job is going to talk about the importance of the whole definition. Drs. Ballard are going to talk about the evolution of the disease, and Dr. Bland is going to contribute some of his research relative to how mechanical ventilation has played a role. We're going to see about the deeper understanding that we've experienced in the BPD pathogenesis, including the sort of new BPD in Drs. Morty, Abman, and Elvira. And then we're going to talk about some of the clinical translational challenges and opportunity with Drs. Morani, Tepper, and Baker. And we're going to close by really talking about the innovative diagnostic and therapeutics that are becoming at the very forefront with Dr. Thibault, and Dr. Corbamas. So with that, I'd like to say thank you to everyone for coming. I'd also like to thank the organizing committee. There'll be more thank yous later. And now I'd like to move into this wonderful video that I hope that you're all going to enjoy. Thank you so very much for being here. I'm remarkably appreciative. Well, here we are with two of the fathers of neonatal medicine and pediatric radiology. It's really my tremendous honor to be with you, Dr. William Northway, and with you, Dr. Philip Sunshine, here today to talk a little bit about how we came to be here today in this room to talk about bronchopulmonary dysplasia. Thank you both so much for sharing this time with me. So you, Dr. Northway, were reading films.
Correct.
And you were looking at these babies. Tell me a little bit about what you saw and the environment that allowed you to come up with your notion surrounding lung disease in these infants?
Well, it was really important that these infants survive, and they were working very hard to ventilate them, and that was new. And they were working very hard to figure out what amount of oxygen to use, because it became clear, and I did some experiments in newborn mice, that 100% oxygen could really badly affect the lung.
So what did you see in these x-rays, and how did you correlate that with what people were seeing in the clinical setting?
Well, in the x-rays, I saw that the infants were actually being ventilated and that their lungs were expanding, but I also began to see changes in the lungs which were disturbing, in the sense that there were some infiltrates, little changes in the lung. And then as it went on, lungs were becoming stiffer. And it was a very difficult but exciting time, but it was very hard. Is that
well,
fair?
then he really described the cystic changes. It went from
Correct.
the hyaline membrane disease to respiratory distress syndrome, and then infiltrates, and then these later stages were the severe cystic changes.
Right, and that was new, and we hadn't seen them before, and it was very worrisome.
And you have to realize, when we ventilated babies, we didn't have a Veriflow to say how much oxygen. We had a choice of using 100% oxygen, 40%, or room air.
Right.
We knew when to put babies on, but then when the babies are ready to be weaned from the ventilator, that was difficult. How do you tell this baby's going to be able to make it?
So Bill, a lot of people would argue, as I've said before, that one of the greatest strengths of that paper was the correlation between the clinical presentation, the radiology pictures, and the actual pathology that was noted.
Okay.
How was it that you were so confident of the clinical presentations and the clinical situation that you encountered? Did you actually go see the patients?
Oh, yeah. Phil knows. I went up and I'd look at them, and I'd look at the x-ray, and I'd look at the patient, and I'd talk to the people that were taking care of them. And we were all on the cutting edge. I mean, right, this was not being done. I mean, that's not fair. It was being done other places, but just starting. And we were all concerned. We all wanted the kids to do well for themselves and the parents and so forth. But, you know, it's cutting edge. And when you're on the cutting edge, good things happen and other things happen. So.
Yeah, but he's one of the few radiologists who would actually come and examine the babies.
So that's the crux of the question I had. So you made sure that clinical description fit with your clinical examination.
Absolutely. And
But
I
he
was
used
working.
to-
Go ahead.
He used to pick up things that we missed. The classic example was a patient with neurofibromatosis. This is actually on the pediatric wards that had nodules along the peripheral nerves that we all missed. And Bill examined the patient and picked this up and discussed it at a conference. And I remember one of our faculty asked, "Why are you examining our patient?"
So tell me a little bit about the paper itself. It came out in '67.
Right.
And why did you choose to publish it, for example, in New England Journal?
Good question. I wasn't going to publish it in the New England Journal. I was going to publish it in a radiology journal like Radiology. And so I took it to my division diagnostic radiology chairman, Herb Abrams, Dr. Herb Abrams, who became famous later for his work in cardiovascular imaging. And I said, I'd like to publish this in Radiology, which is a very good radiology journal. And he took one look at it and said, no, it's too important. We're going to publish it to the New England Journal of Medicine. I said, they'll never accept it from a junior faculty in radiology? And he said, oh, they'll accept this one. He went over it, and he was an English major as well as a physician radiologist. So he went over it. So he improved my writing. It was beautifully written with his help, thank God. We went over all the numbers in the paper, you know, the laboratory numbers, and we sent it in. And as I recall, it was initially, they sent it back. Not that they rejected it. They sent it back, but they had questions about this number and that sort of thing. So he had it all gone over again, sent it back to him, and they published it.
So, but how about once it got published, Dr. Northway? Did you get a lot of reaction? Was there reaction within the institution?
I got a lot of reaction in a variety of ways. Some people said, editorially wise, we never see this. Fair enough, remember that? They were saying that. And I thought, well, maybe, I was upset that they weren't seeing it. I was glad they weren't seeing it. So I would go back east and speak to them in Boston or Massachusetts or wherever it was, Virginia, and say, okay, now I came back to see what you're doing that we're not doing so we can improve, because I wanted to be positive for them. Well, then when I got in the small meetings with them, they were seeing exactly what we saw.
The paper had 3 authors on it,
yes.
A pediatric radiologist.
Correct.
And 2 pediatric pathologists.
Correct.
And yet it came from the Department of Pediatrics as well.
Right.
Why weren't there any pediatricians on the paper?
That's a very sore point. And the problem was that the person who was directing our nursery felt that it was a black mark at Stanford.
And I had invited all the pediatricians I worked with to be co-authors, including Phil. Every single one I worked with, I said, join me on this. And many of them wanted to do it, but the chief didn't feel he felt it was a black mark on it.
So we felt that if he felt that way and didn't want his name on the paper, rather than blocking it, we just said, don't put any of our names on it.
So do you guys think that this idea of reporting less than perfect outcomes was a helpful thing to do?
Oh, definitely.
Oh, yeah.
No question about it.
It changed care.
Yeah.
That's fair. It really changed care.
Let me just ask you a question about the paper as well. There were 49 references in the paper, and 48 of them were to other articles. One was, you referenced a personal communication with several of the pediatricians, including Phil Sunshine. How many of those references do you think you actually read in preparation for writing that manuscript?
Oh, I'd read all of them.
You'd read all of the
I
references?
don't put a reference down that I haven't read.
Uh-huh.
No, they're all read.
And,
No, I don't just say, oh, and so-and-so said. No, I would go read it. So if they're there, they played a role.
You have to realize he's one of the true investigators. Even though there were some of his patients, especially when he was doing the work with the mice, that didn't quite fit the protocol, rather than throwing those out, he included all of these. So whenever Bill wrote a paper, you knew that all the data were there. Everything that he wrote was well documented, and he was a true scientist. I never thought I'd say that about a radiologist, but that's the truth.
how much do you think sort of the context, being in that place, in that environment, with these sorts of people, in a nursery that was arguably a human biology laboratory, changed the way that you thought about these problems?
Well, the care of the babies changed tremendously during this period of time.
Yes.
Intravenous nutrition came into play. We were fortunate, serendipity. We had one ventilator that had a sticky valve. It was one of the old Bennett PR2s.
Yeah, Bennett PR2s.
And we noticed that babies who were on this ventilator did better. Then we realized that we had an inspiratory time. Prior to that time, the ventilator would work, you'd get a pressure come down. This time we had a little inspiratory time. And it had inadvertent PEEP, which we couldn't measure on the dial.
Positive expiratory.
But so that improved our outcome with a survival rate of somewhere in the 40s all the way up over 60%.
Yeah, it was big.
So what about this name, bronchopulmonary dysplasia? Where did that come from?
Well, I looked at what was going on, and what the changes that were happening affected the airways, the bronchi, the lungs, pulmonary, and it was a dysplasia. It was in a growing, immature lung, and it changed the way the lung went. So we called it bronchopulmonary dysplasia. It turned out BPD became commonly known, but I didn't know it at the time.
Some people recommended it called bronchoalveolar dysplasia,
Yeah.
but that would have been bad. But BPD sounds so much better.
That would have been bad.
That's right. It would have been bad, yeah.
So what do you want to tell physician scientists today?
You know, when you see something wrong and you think you might have a way to make it better, get things back to where you'd like them to be, you want to pursue it. And pursuing it is gotten more difficult, but it's still worth doing because you may be able to really change somebody's life.
The problem that you originally described has largely been ameliorated.
Ameliorated, right.
And now we've pushed back the frontiers, and we're standing on the shoulders of giants, and now looking at a new manifestation of neonatal lung disease. So knowing what you have done in terms of really making therapy pretty straightforward for a 33, 32, 34-week baby, which when Phil was starting out, that was a dicey proposition.
Well, the big thing is that if you were 28 weeks or below, you had less than a 10% chance of surviving.
Correct.
Now, if you're at 28 weeks, you have about a 90% chance of survival.
Yeah, it's really changed.
As we are pushing back the frontier, a lot of us are very nervous about how far back we can go. Mm-hmm. We know we can have these babies survive, but we don't know how they're going to survive, what kind of handicaps they will have.
Right.
On behalf of pediatric pulmonologists, neonatologists, pediatricians, cardiologists, parents, children everywhere, I want to really thank you both sincerely and profoundly for everything you've done for the field, for all of the children, for so many years. We truly do stand on the shoulders of giants, and thank you for that privilege.
Well, it's our pleasure.
Thank you.
He's the giant.